Remember all that time you spent memorizing myotomes, dermatomes, and reflexes throughout physical therapy or med school? At the time, it appeared to be a clear-cut way to clinically assess a neurologic system. But as I'm sure many of you would agree, or will soon to find out, there are some noticeable flaws in this assessment. So in this video, we will take a deeper dive into these flaws and provide you ways that you can enhance the effectiveness of your neurologic examination. Hey everybody, welcome back for another episode of PhysioShow. Conducting a clinical neurologic examination is key to diagnosing peripheral neuropathies, including anything from lumbar or cervical radiculopathy, carpal tunnel syndrome, and even diabetic neuropathy. The goal of the assessment is to pinpoint the loss of action potential conductivity, or the ability of the nerve to send impulses. This is indicated by the loss of sensation, motor function, or diminished reflexes. These impairments are key indicators of the presence of peripheral neuropathies. But there are two issues with the traditional neurologic examination. The first is patient variability, and the second is flaws in the examination process itself. Let's start with the patient aspect. There exists significant variability in patients that can dramatically impact the interpretation of the results of the neurologic examination. For example, studies have shown that those who have confirmed disc herniation may not present with alterations in dermatomes, myotomes, or reflexes, or may present with some deficits and not others. Even the specific distribution of radicular pain symptoms has been shown to have low diagnostic accuracy. For instance, you would think based on teachings that those who experience radicular pain down the back of the thigh and calf may be presenting with an S1 or S2 nerve root issue. However, studies have shown that individuals are just as likely to experience pain in this distribution when receiving epidural injection at the L3, L4, or even L5 levels. These inconsistencies are seen with reflexes as well. For example, the patellar tendon reflex, which is often used to assess the L3 spinal level, was found to be diminished in around 30% of patients with confirmed L5 radiculopathy. So the absence of these symptoms doesn't necessarily rule out the presence of radiculopathy. And even when symptoms are present, they may not precisely align with a specific segmental level. While there may be inconsistencies in patient presentation, it is also important to consider the impact of the traditional way the neurologic examination is conducted, as this too may be influencing its reliability. Let's break down each component to highlight this more. It is commonly taught to assess sensory changes at key sites that follow a dermatomal pattern. We do this to minimize dermatomal overlap and enhance our ability to detect nerve root involvement. But dermatomal maps can vary depending on the reference you use, so one clinician may determine an L4 dermatomal change, while another believes it to be an L3 dermatomal change, simply because of the textbook they learned from. Not only this, but neuropathies affecting distal peripheral nerves, like carpal tunnel or cubital tunnel syndrome, are more prevalent than radiculopathies, yet the standard dermatomal assessment does not always cover these more peripheral nerve innervations. This can result in clinicians overlooking the more distal nerve conditions. So to improve your neurologic examination, the sensory assessment should be conducted in a circumferential pattern, rather than using the typical point testing, which is based on inconsistent maps for dermatomes and peripheral nerves. Start by tracing two circles around both the upper and lower arms or legs. This will allow you to hit the majority of dermatomes and peripheral nerve innervations in the region. This should then be followed by a single-digit testing of both the anterior and posterior aspect of the hands and feet. When it comes to motor testing, clinicians will commonly observe for muscle atrophy and utilize manual muscle testing of a single reference muscle, along with functional assessments like heel or tiptoe walking. But relying solely on reference muscle testing lacks the capacity to distinguish between compromise at the nerve root or distal peripheral nerves, as they can overlap. Also, nerve roots supply a variety of muscles that can vary between individuals, so using just a single reference muscle to screen for involvement is not enough to distinguish if this is a nerve root issue or a peripheral nerve issue. For example, weakness in the extensor pollicis longus could stem from either C8 nerve root or radial nerve lesion. The typical myotomal assessment can also underestimate the presence of motor deficits, as it may not induce sufficient neuromuscular fatigue, which is a common symptom in patients with peripheral neuropathies. So patients with minor motor deficits who require a higher motor demand to induce neurologic fatigue may be missed. So to enhance your examination, assess multiple muscle groups that are innervated by the same segmental nerve root, but by multiple peripheral nerves. This will help you differentiate the two. And when motor symptoms are more indicative of fatigue versus maximal muscle strength, it would be beneficial to evaluate motor function after physical exertion or using repeated testing to detect neurologic fatigue. Clinicians will also commonly compare sensory, motor, and reflex responses on both sides to determine the presence of impairment. However, research has shown that patients with strictly unilateral neuropathies can actually experience sensory changes on the other side to a lesser extent, like a weird mirroring effect. Not only this, but many peripheral neuropathies present with bilateral involvement, so this impacts the ability to use the other side as a comparison. And it's not uncommon for normal age-related changes to occur, with approximately 1 in 4 healthy adults over the age of 60 exhibiting absent bilateral ankle reflexes. So not only is it common for unilateral peripheral neuropathies to be mirrored on the other side, but the presence of diminished reflexes does not necessarily mean it's pathological. To account for the unreliability of using the other side as your reference standard, cluster together multiple muscle groups and reflexes. When assessing sensation, utilize unaffected proximal areas as a reference. While this is not perfect, it will help provide some clarity about the results. And if you're finding value in this video, make sure to hit the like button to help it spread and help out more people like you. It goes a long way in helping us achieve our goal in spreading best practice. Now let's get back to the video. Another concern is that common assessments like light touch, muscle strength, and reflex testing target mostly large diameter nerve fibers and are inadequate in assessing the function of small A delta and C fibers. These smaller fibers are often affected in various peripheral neuropathies. Changes in small fiber function can often occur in the absence of deficiencies in large fibers, as observed in conditions like small fiber neuropathy. So depending solely on tests that assess the integrity of large nerve fibers is likely to overlook the presence of small fiber peripheral neuropathies. To avoid missing small fiber neuropathies, you can utilize mechanical pain and thermal assessments. Paper clips for pinprick and warm and cold coins can be cost-effective and accessible assessment tools. So as you can see, the traditional approach to the neurologic exam is limited by both patient presentation and the methodology. For this reason, it is important to utilize a more systematic approach in order to enhance the accuracy and reliability of your neurologic exam. Well, I hope you enjoyed this episode of PhysioShow. If you enjoyed it, please don't forget to hit the like button and consider sharing this video to help it spread. Your support is key to spreading best practice and fostering a greater understanding of our body, how it works, and what it needs to keep moving.